I'm Dr. Franco Castro-Marin, EMS Medical Director of the City of Scottsdale and Scottsdale Healthcare Hospitals. The objective of this video is to introduce to you our new spinal injury assessment and spinal motion restriction protocol. Over the past 30 years, we've developed the tradition of applying spinal immobilization to our patients based almost entirely on mechanism of injury, regardless of the clinical signs and symptoms. We were taught that immobilization was absolutely vital to protect the spine and spinal cord from further harm. Slowly, we have come to realize that the standard immobilization tools and techniques actually have the potential to create further harm. Because of this, the decision to immobilize a patient has to be made more carefully and deliberately. The process of deciding whether or not to immobilize a patient is more evolved thanks to proven, reliable patient assessment concepts that we are taking beyond the emergency department and into the pre-hospital environment. We still consider mechanism of injury, but a specific assessment criteria will now be at the center of your decision-making process. It all comes together to create a more intelligent process to decide what steps need to be taken to protect your patient, but also what steps to avoid to prevent further harm. Up to 5 million patients undergo spinal immobilization per year in the United States. Less than 1% of these patients actually have spinal injuries. One study showed that up to 13% of patients were immobilized without even being asked about the presence of neck or back pain. It is a fact that spinal immobilization has the potential to harm patients. For example, cervical collars have been shown to increase intracranial pressure. They apply a distraction force to the cervical spine. They can conceal penetrating neck wounds. Although they minimize visible movement, they transfer force to other areas of the spine. Longboards can create pain in patients who otherwise had no pain. This can sometimes result in diagnostic imaging that otherwise may not have been necessary. Longboards can cause decubitus ulcers within 30 minutes, especially in patients with sensory deficits. Patients are prone to slip motion on spine boards that can cause more unintended movement of the head, neck, and spine. Supine positioning of the immobilized patient can decrease respiratory capacity up to 20%. Also, we are all aware that patient packaging takes time and personnel. Transport delays result in worse outcomes for critically ill trauma patients. Couple all of this information with the fact that there is very little evidence to show that spinal immobilization actually does anything to improve outcomes of patients with blunt or penetrating trauma. We cannot be cavalier or hasty when deciding to perform procedures on patients that have the potential to do them harm while offering little in the way of actual benefit. As we start to explore our new algorithms, which we are calling spinal motion restriction or SMR, we first want to focus on penetrating trauma victims. Patients of any age who have suffered penetrating neck trauma to the head, neck, or torso are extremely unlikely to have unstable spinal fractures or spinal cord injuries. When they do have such injuries, a focal neurologic deficit is present from the moment of injury. We do not want these patients to undergo spinal motion restriction unless they have a focal neurologic deficit that is directly related to their penetrating injury. Also, if you have a patient with penetrating trauma who then suffers a secondary blunt injury, such as a patient shot who then falls down a set of stairs, you should then defer to the blunt trauma algorithm. Someone with global neurologic dysfunction, such as a comatose patient who suffered a single gunshot wound to the head, will not benefit from spinal motion restriction. Now let's focus on blunt trauma patients and the precise way by which we ought to examine them for potential spine injury. It all begins by quickly determining if your patient has experienced any sort of injury mechanism that had the potential to cause an unstable spine injury. We provide a table that summarizes some high-risk mechanisms that deserve consideration. The first important concept to notice here is that mechanism alone will not direct you to immediately apply SMR.
So how high up on that ladder were you?
Oh, about halfway.
About halfway up the ladder. Are you
If you feel that the potential for spine injury is there, it simply should direct you to further assess the patient in more detail. We have 3 criteria that must be met convincingly. All 3 of them have to be met, and your documentation has to support that accordingly. First, find out if your patients are alert and reliable to participate in the complete evaluation. They must have a normal GCS of 15 to be considered alert. Then you decide reliability. Is there anything that hampers communication or understanding, such as a language barrier or lack of insight? Do they cooperate with you? Painful distracting injuries, such as long bone fractures, could actually affect a patient's ability to interact with you reliably and cooperate with the rest of the exam. Do they appear intoxicated in any way? If they seem alert, sober, cooperative, and reliable, then you can proceed to the second step, which is the spinal exam. Palpate the vertebral processes, the entire spinal column itself along the neck, torso, and lower back to check for pain or tenderness. Feel for any step-off or deformity. In kids, the exam should also check for limitation in neck movement. The final part is a simple but sophisticated neurologic exam, checking motor sensory function in all four extremities, making sure that there are no deficits or abnormalities anywhere. All right, show me both hands out like this for me. Keep them nice and firm, don't let me move your muscles. So we're going to press on the fingers here. He's got good strength there. We're going to try to move the hands back and forth, and he's nice and locked in there, showing good strength. This extension maneuver represents the lowest cervical and then highest thoracic nerve level. If I just ask him to squeeze my fingers, that's actually a little bit higher in the cervical spine. It doesn't give me information of the lowest cervical level and that powers the upper extremity. So we want to see extension. Good, thank you very much. All right, now we're going to check down on the lower extremities. Point your toes towards your nose for me. Nice and firm. Good. And now push down for me. Good. All right. Are you having any numbness and tingling anywhere along the legs here at all?
No.
All right, show me your hands one more time. Any numbness and tingling here on the hands at all?
No.
No, good. And so after you've checked your motor strength in the upper and lower extremities, then the key thing is checking with the patient that they have no areas of numbness and also no paresthesia. So specifically tingling, if they're reporting that, that is a bad sign and makes you concerned about some sort of spinal cord injury. To state it simply, if the patient is awake and alert, the spine doesn't hurt, and everything works, spinal immobilization is not needed and SMR should not be applied. Let's consider spinal cord injuries for a moment. You can divide up our patients into three broad categories. Those with irreversible devastating cord injuries and those with totally normal spines are the large majority, and our spinal immobilization techniques do nothing for them. When the spinal cord is totally severed after trauma, the result is a completely permanent injury. The cord could be severed by bony fracture fragments, traveling projectiles, or stabbing objects. There is simply no step that we can take in the pre-hospital setting that will make that type of injury any worse or any better. However, it is likely that these patients will have other critical injuries that require urgent treatment, and delaying that treatment in order to immobilize them could bring them potential harm. The minority category includes those patients with biomechanically unstable partial spinal injuries. The patients may have either permanent or temporary damage, usually from direct compression, edema, or vascular injury causing tissue hypoxia. The cord could also be bruised. The common denominator is that all of these mechanisms cause physiologic changes that result in cellular death. These problems are very time sensitive, and there are very few things that we can do to improve the situation other than to get the patient to a definitive care at a trauma center. The terms stable and unstable specifically refer to the bony vertebral column, which is conceptually divided into an anterior and posterior section. If the injury only involves one section, such as a simple compression of a vertebral body or a fracture of just a spinous process, the other section still maintains the normal configuration of the total spine under physiologic loading. This is considered stable, and normal movement and handling of a patient with such an injury should not result in further harm. On the other hand, if the injury damages both the anterior and posterior section of the vertebral column at the same level, then the spine has the potential to move as two completely separate objects. Risk of further compression injury to the cord may be much higher. The way that we protect a patient in this situation is to minimize force and mechanical work at the site of injury. The exact method by which you do this may change depending on the specific situation. Your overarching goal should be to avoid global hypoxia by supplying supplemental oxygen or through advanced airway management. Minimize any delays in definitive treatment. When deciding how to package the patient, keep these general concepts in mind. Comfortably firm, high-friction surfaces such as the gurney mattress are better than slippery, rigid backboards. Vacuum mattresses are ideal because they dissipate energy over a large surface area and they provide lateral support along the entire head and body. Standing takedowns have become commonplace, but actually they don't make much sense. This is because ambulatory patients are highly unlikely to have unstable spines. Furthermore, the takedown maneuver applies a distracting force along the entire spine. It makes more sense to walk the patient to the gurney with the back section in the upright position. Then once seated, you can gently lower the patient to a supine position. After that, secure them with straps as needed. Most important of all, it does not help the situation to force a combative or seizing patient into spinal immobilization. Their fighting will only increase force and mechanical work along the entire spine. The same is true for stable, alert, but uncooperative children. Now, when it comes to mechanism of injury, it's important to drill down to just one basic question. What was the mechanism of movement to the spine itself? We like to think in terms of flexion, extension, rotation, and application of an axial load. Consider how the spine traveled through space, with what force, and how much energy it had to absorb to come to a stop. If you decide that there perhaps has been enough force and energy to break a bone or tear a ligament, then that is precisely the time where you want to have a lower threshold to apply spinal motion restriction. It's also important to consider the patient's other health problems. Conditions like osteoporosis and others can actually compromise bone strength. Patients with these problems have spines that are less able to withstand the same energy as patients with normal, healthy spines. They may suffer injuries with even less severe mechanisms. Children and infants have more cartilage and more elastic ligaments in the spine compared to adults. They're able to experience more vertebral displacement even without a fracture and could injure the spinal cord in that manner. Up to 30% of patients with Down syndrome may have atlantoaxial instability just below the skull base that can put pressure on the spinal cord even within the normal range of motion. Geriatric patients in general have more brittle bone and stiffer ligaments that tend to structurally fail with less force. You can find a summary of high-risk patient characteristics and mechanisms on the Blunt Trauma SMR algorithm page. For adults, these include age greater than 65, trauma mechanisms from the trauma triage offline that might meet level 1 criteria, axial load or diving injuries, and neurologic signs such as numbness, tingling, and paresthesias. For people younger than age 15, experts specifically consider high-risk characteristics of vehicle crashes, such as rollover or head-on, ejection of the patient, death in the same vehicle, or speeds greater than 55 miles per hour. In a child, it's also considered high risk if you have any type of substantial injury to the clavicle, abdomen, flank, back, or pelvis. Low-risk criteria are also listed. The presence of any of these in an otherwise normal patient predict that it is safe to transport without applying SMR. These include low mechanism rear-end collision auto accidents, or if the patient was ambulating at any time after the injury, or the absence of neck pain on the scene, or the absence of midline cervical spine tenderness on examination. The information that we've presented here may seem rather bold or unorthodox. The process of implementing this change of practice in the pre-hospital setting may seem a little uncomfortable. However, the reality is that these concepts are not new. They are based on current emergency medicine practice standards and high-quality medical research. It is important that you become proficient with this information. It's all designed to augment your knowledge about spinal injury so that you can take better care of your patients.